The culture of healthcare. Welcome to the culture of healthcare. This is evidence-based practice. This is part 7, the final part of our series on evidence-based medicine. So, we're going to continue to explore the culture of healthcare, the expectations of working in health settings, how care is organized within practice environments, and the vital importance of privacy laws. We'll also touch on the professional and ethical issues that clinicians, healthcare providers, and clinical engineers encounter in their daily work. And by the end of this session, by the end of this series, you'll see how the culture of healthcare not only shapes evidence based practice, but also guides the decisions, responsibilities, and values that define modern healthcare. Objectives for evidence-based practice through clinical engineering. So here we're going to finally describe how EBM is used in clinical settings through clinical practice guidelines and decision analysis. So with clinical engineers, this aligns with evidence-based guidelines when ensuring that devices meet regulatory standards, accreditation requirements, and professional best practices. Decision analysis tools such as risk benefit models or cost effectiveness studies. These guide hospital leadership in adopting or retiring technologies. Engineers serve as the bridge between abstract guidelines and the practical realities of daily healthcare operations. Here we turn our attention to two important tools in evidence based practice guidelines and decision analysis. Practice guidelines are designed to translate the best available evidence into clear, actionable recommendations for clinicians and healthcare providers. They help standardize care, reduce variation in practice, and ensure that patients receive treatments supported by strong evidence for clinical engineers. These guidelines also shape the way technologies like imaging systems, infusion pumps, or monitoring devices are selected, implemented, and maintained in alignment with patient safety and other clinical effectiveness. So, decision analysis, on the other hand, this provides a structured way to think through complex clinical and technical choices by weighing probabilities, risks, benefits, and costs. Decision analysis allows healthcare workers and engineers to evaluate alternatives systematically, whether it's deciding on a treatment plan or determining the most reliable technology to support patient care. Decision analysis helps ensure that choices are grounded in both evidence and logic. So together, practice guidelines and decisions analysis demonstrates how evidence-based practice moves beyond theory, giving us practical frameworks to improve care, manage risk, and support sound decision making in healthcare systems. A clinical practice guideline is essentially a structured set of recommendations, sometimes organized as a step by step process or what we often call an algorithm. And these guidelines walk us through the delivery of care, whether it's the diagnostic workup of a patient or the steps involved in treatment. Guidelines can be presented in different formats. Sometimes they're written out as text or summarized in tables, but often the most useful form is a visual algorithm that shows the sequence of decisions and actions. Within an algorithm, there are several kinds of steps. We have action steps, which are clear instructions for what to do next. Then we have conditional steps, which are directions that depend on whether a criterion is met. For example, if the blood pressure is above this level, then do this. We have branch steps, which points where the process splits into two or more possible pathways. And we have synchronization steps, where those different pathways come back together into a single sequence. And for clinicians and clinical engineers alike, guidelines and algorithms provide a map for decision making, helping us ensure care is consistent, evidence based, and easier to follow in complex situations. This slide shows a very simple practice guideline that might be used, for example, to decide whether someone should get a flu shot. The recommendations on who should get a flu shot vary, but in this guideline, we see who they're recommending it for. And our first action step in the guideline is to collect some data. We branch because we need to get two pieces of data, the occupation of the individual and his or her age. We wait until we get both pieces of data, which is synchronization step one. We then reach conditional step one, where we ask if the age is less than 12. According to this guideline, we should immunize everyone who is under the age of 12, and we should use the pediatric dosage that is modified for their weight and size. Of course, the actual recommendations vary, but this example is meant to illustrate how an algorithm works. Again, the first action step is to collect some data. Here we branch into two questions, the individual's occupation and their age. Once we have both, we reach a synchronization step, bringing the information back together. Next comes a conditional step one. Is the person under the age of 12? If yes, the guideline says to immunize all children under 12 using the pediatric dosage adjusted for their weight and size. If no, we move to the next condition. Is the person a healthcare worker or are they over 65? If yes, we give the adult dosage. If no, we stop here in this simplified example. No flu shot is recommended. Again, though in real practice, the guidance would likely be much broader. And the point of this example isn't the medical accuracy of this flowchart. It's to show how a guideline algorithm uses action steps, conditional steps, branches, and synchronization points to walk us through clinical decision making. So for clinicians and clinical engineers, these structures make care delivery more consistent, transparent, and easier to evaluate. How do we appraise a clinical practice guideline? Appraising a clinical practice guideline is a little different from appraising a randomized control trial. In some ways, it's simpler. We only have a few core questions to ask, but guidelines are also more complex with many steps and recommendations that need to be examined carefully. If we retrieve a guideline and are considering whether to put it into practice, we can focus on three key questions. First, did the developers carry out a comprehensive, reproducible literature search within the last 12 months? In other words, is the guideline up to date? If the topic is diagnosing a certain cancer or treating diabetes, are the recommendations based on the latest and most complete evidence? Second, are the recommendations tagged by the level of evidence and linked to the specific citations? If the guideline tells us to use a particular test or treatment, we need to know what kind of evidence supports that recommendation. Was it based on randomized controlled trials, observational studies, or expert opinion? And where can we find the published research? Third, is the guideline applicable in our setting? This question gets practical. For example, is the burden of illness high enough in our patient population to warrant implementing the guideline? Do the clinicians, engineers, or staff who would use it believe in the value of the intervention? And what about the barriers like cost or workflow changes or lack of access to the required tests or treatment? If implementation is unrealistic, the guideline may be of limited value. So when it comes to appraising guidelines, the key is to ask, is it current? Is it evidence based? And is it practical in our setting? If the answer to all three is yes, then the guideline may be a strong candidate for adoption. Paper versus electronic practice guidelines. So, one of the big questions with practice guidelines is this: is it more effective to use them in paper form or electronic form? The problem with paper is clear. A study by Hibble and colleagues in England collected all of the guidelines mailed to a sample of 22 practices over a single year. The result: 855 guidelines, some just a page or two, others booklets or folders, and when stacked, the pile reached 68 centimeters high, about 27 inches, and weighed 28 kilograms, which is about 62 pounds. Now imagine being a clinician or an engineer trying to pull out the right recommendation from a 2 foot stack of mixed papers. It's overwhelming, it's inefficient, and easy to miss something important. That's why many now argue that guidelines are far more effective when delivered electronically. By codifying recommendations in the electronic health record or other clinical systems, the guidance can appear right at the point of decision making, exactly when the provider needs it. Some systems go further, allowing clinicians to import guidelines directly into the EHR and even tailor them to the specific patient sitting in front of them. For clinical engineers, this highlights the critical role of health IT, interoperability, and decision support systems in making sure evidence based guidelines are not just written, but actually used in practice. Why guidelines aren't always followed. When practice guidelines are available, research shows that physicians often don't adhere to them. Cabana and his co authors found several reasons why physicians were simply unaware of the guidelines. Others disagreed with them, and many just didn't want to change their existing practice patterns. In the United Kingdom, Gabay and LeMay observed that even in highly regarded practices, physicians and nurses rarely assessed formal research evidence. Instead, they relied on what the authors called midlines, internal rationales built from habit, local culture, and peer influence. These mind lines, I'm sorry, I don't know why I said midlines, mind lines, right? So these mind lines sometimes aligned with evidence, but they often didn't. Other research has highlighted the consequences. For example, Lynn studied adherence to guidelines recommending stress testing before percutaneous coronary intervention. These procedures, like angioplasty or stent placements, the evidence is clear unless symptoms are documented by stress testing. Patients should not move directly to intervention, yet many cardiologists skip the step and proceed straight to the procedure. And this raises ethical and practical concerns. In an editorial, Diamond argued that financial incentives may be driving this behavior and suggested the concept of evidence based reimbursement, aligning payment with adherence to guidelines and best evidence. For clinical engineers and healthcare workers, these findings underscore a critical point. Even the best designed guideline is only useful if it's applied in practice. And that requires not just evidence, but also systems, incentives, and cultures that support evidence based decision making. Limitations of practice guidelines. While practice guidelines are valuable, they're far from perfect, and it's important to understand their limitations. One major challenge is applying guidelines to complex patients. So, a study by Boyd and colleagues looked at guidelines for 15 common diseases and asked whether they could be applied to elderly patients with multiple comorbid conditions. And their conclusion, following the guidelines to the letter, could actually have undesirable effects because recommendations for one disease might conflict or worsen another. And if guidelines were tied to pay for performance schemes, physicians might be penalized for deviating, even if tailoring care away from the guideline was actually in the patient's best interest. Another challenge lies in implementation. Integrating guidelines into electronic health records isn't easy. The logic in guidelines is often vague or nuanced, and it doesn't always fit neatly into the rule based decision support system. A paper by Maviglia and co authors highlighted several examples of how difficult it can be to align guideline logic with real world workflow. There's also the issue of conflicts of interest. Research shows that about 87% of guideline authors have ties to the pharmaceutical industry, and more than half, about 58%, receive financial support for their research, and some even serve as employees or consultants to pharmaceutical companies. These relationships raise legitimate questions about objectivity and whether certain recommendations may be influenced by industry interests. And finally, even when a guideline is sound, it may not be practically feasible. Some recommended services or activities may not be covered by insurance or may be denied for reimbursement, and this creates yet another barrier between evidence based recommendations and real world practice. So, in short, practice guidelines are powerful tools, but they need to be used with the critical eye, balancing evidence, practicality, and patient centered judgment. The future of clinical practice guidelines. So, what does the future look like for clinical practice guidelines? Many healthcare systems are already convinced of their value. Guidelines help to standardize care, improve outcomes, and in some cases, even lower costs. As healthcare continues to emphasize quality measures and pay for performance models, the use of guidelines will almost certainly expand. The growth of electronic health records is another driving factor. Guidelines can be embedded directly into clinical systems, making them easily available at the point of care where decisions are made. And this integration increases the likelihood that guidelines will be followed in day to day practice. And importantly, guidelines are becoming more accessible. For example, the National Guidelines Clearinghouse offers a database of over 1,000 guidelines, most of which can be freely downloaded. Both for clinicians and clinical engineers, the future is clear. Guidelines will continue to play a central role in shaping practice, supporting decision making, and ensuring that healthcare delivery is grounded in evidence. Now let's look at decision analysis. Decision analysis applies a formal structure that allows the integration of evidence about both beneficial and harmful effects of treatment options with associated data use and preferences. So, decision analysis enables us to explicitly lay out the factors that go. Now, let's turn to decision analysis. Decision analysis performs a formal structure for decision making. It allows us to bring together evidence about both the beneficial and the harmful effects of different treatment options, and to combine this with data on resource use and patient or system preferences. The strength of decision analysis is that it makes the process explicit. Instead of relying on intuition alone, we can lay out all the key factors, assigning numerical values where possible, and then calculate a quantitative measure to help guide the decision. Decision analysis can certainly be applied to the care of a single patient. For example, choosing between different therapies based on risks, benefits, and patient preferences. But in recent years, its use has expanded to the policy level. Health systems, regulatory agencies, and even engineers designing medical technologies now apply decision analysis to weigh costs, benefits, and risks when setting guidelines, approving devices, or allocating resources. So, in this way, decision analysis bridges the gap between clinical evidence and real world choices, giving both healthcare providers and, in this case, clinical engineers a systematic tool for making complex decisions. Example of decision analysis: anticoagulation in atrial fibrillation. So let's look at a simple example of decision analysis, deciding whether to use anticoagulation in a patient with atrial fibrillation. Now, I know this is a medical case, not an engineering one, but it's important, like I said before, for engineers to understand the type of decision making and the models that are used by healthcare workers. Okay, so atrial fibrillation occurs when the upper chambers of the heart, the atria, begin to fibrillate or quiver because blood isn't pumped out effectively. And it can accumulate and form clots. If the heart returns to a normal rhythm, a clot can be pushed forward, sometimes traveling to the brain and causing a stroke. So, what are the options for preventing a stroke in these patients? Essentially, there are three. And the first is to do nothing. So, no prophylaxis. The second is aspirin, a mild blood thinner. And the third would be something like warfarin or Coumadin, which is a stronger anticoagulant. And for each option, there are two possibilities. The patient either has a stroke or does not. But with anticoagulation, there's also the possibility of bleeding. And that gives us four possible outcomes for each treatment path: no stroke, no bleed, the best case. So, stroke, no bleed, or no stroke but bleeding, and then stroke with bleeding, which is the worst case. So the medical literature tells us that warfarin is more effective at preventing strokes than aspirin or no treatment, but it also carries a higher risk of bleeding. In a decision analysis, we would assign numerical probabilities to each outcome based on evidence and then weigh them to calculate the overall value of each treatment option. In diagrams, the diamond represents the decision node, the choice of treatment, while the circles represent chance nodes, showing the probabilities of different outcomes. And by making the trade offs explicit, decision analysis helps us decide, is the extra protection against stroke with warfarin worth the increased risk of bleeding? For clinicians and clinical engineers, this illustrates how evidence and probability can be structured to guide better data informed choices. How do we actually use a decision analysis? The process involves assigning numerical values to each of the possible pathways through the decision tree. And these numbers come from two main sources: evidence values, probabilities of outcomes drawn from the medical literature, and utility values, patient preferences about which outcomes are more or less tolerable. For example, some patients might say they could tolerate a mild stroke better than a serious bleeding event. Others might feel the exact opposite. In surgical cases, patients may be more willing to accept the short term risks of surgery if it means avoiding the possibility of a much worse long term outcome. And once we've entered these evidence based probabilities and patient centered utilities into the decision tree, we apply a process called folding back the tree. And this means we work backward through the tree, calculating expected values at each chance node until we identify the optimal pathway. The option that balances risk, benefits, and patient preferences is the most effective. So for clinicians, this ensures that decisions are based on both data and values. For clinical engineers, the same approach can be applied to technology choices, balancing reliability, risk, and cost when selecting devices or designing care systems. While decision analysis is a powerful tool, it does have its limitations. First, it often presents an idealized version of reality. The structure of a decision tree can make choices look neat and precise, but in practice, patient situations are rarely that simple. Still, even if it doesn't capture every nuanced decision, the analysis provides a valuable framework, one that clinicians and engineers can use to either follow or thoughtfully deviate from a standardized approach. The bigger challenge comes when we try to apply decision analysis to individual patients. Building a detailed decision tree is time consuming and it relies heavily on assigning numerical values to things that may not be easily quantifiable, like how much risk a patient is willing to tolerate for one outcome versus another. Because of these challenges, decision analysis hasn't had a major impact at the individual patient level. Where it has proven most useful is at the policy level, helping health systems, insurers, and regulatory agencies make informed decisions about treatments, technologies, and resource allocations. So while decision analysis is not a perfect tool for exam rooms, it remains a valuable method for shaping evidence based policies that affect clinical practice and technology that's used more broadly. And this concludes part 7 of our series on evidence based practice. So, in this series, we explored the two main approaches for making recommendations based on evidence: clinical practice guidelines, which provide structured steps and decision points for delivering care in a consistent evidence based way. We discussed decision analysis, which offers a framework for weighing risks, benefits, and preferences to arrive at the most optimal decision, whether for a single patient or at the policy level. And together, these approaches help clinicians, healthcare workers, clinical engineers to bridge the gap between evidence and practice. This ensures that care decisions are both scientifically sound and practically applicable. And to recap the entire series, throughout these lectures, we've seen how evidence based medicine provides both the tools and the disciplined approach needed to support clinical decision making. It helps us identify the best available evidence to answer the four fundamental types of clinical questions. So, interventions: what treatments work best? Diagnosis: how to identify diseases accurately. Harm: what exposure or interventions may cause adverse effects. Prognosis: how diseases or technology shapes patient outcomes over time. And finally, evidence based medicine provides two structured approaches to translating evidence into action. and that would be the clinical practice guidelines, which gives step-by-step pathways for care, and decision analysis, which offers a framework for balancing risk, benefits, costs, and patient preferences. Together, these methods ensure that both clinicians and clinical engineers can make decisions that are not only logical and efficient, but also scientifically grounded and patient centered. I want to thank you for joining us for this series on evidence based practice. Thank you for your time. Thank you for your listening. And I'll see you on the next section.